All right. Okay. Here we go. All right, let's get started. Thank you so much for coming. We're going to talk about the acute management of stroke. I will say, before we get started, these are kind of our goals. We'll talk a little bit about classification, and I'm really going to be following along with the 2018 guidelines that were published by the AHA and the ASA. So when I approach such a big topic, and we did this with atrial fibrillation and STEMI as well, I like to kind of follow these guidelines because it really frames such a complex topic and gives you like a good way to approach it. We're going to talk about interventions, we're going to talk about imaging, quite a bit about imaging, and then interventions besides TPA and EVT, EVT standing for endovascular therapy. And we are going to dive into the TPA and EVT literature a bit. Try not to fall asleep during that. And I will say, again, that this isn't a med school level talk. I mean, we're not going to talk a lot about neuroanatomy or specific stroke syndromes or the differential diagnosis of stroke. I think most of us know that. So this is going to be kind of a higher level talk about just the management of stroke and what we can do for these patients in the ED. And I appreciate so much that the hospitalists and Dr. Das came. But this talk is going to be focused mostly on the emergency department management of stroke. There's going to be some stuff that's pertinent more to the inpatient side, but most of it's going to be what we do in the ED and how we assess, risk stratify, treat, and then dispo these patients. So we're going to be talking about ischemic stroke solely today. I'm not going to talk at all about hemorrhagic strokes. And this is the stroke classification that I learned in medical school, ischemic, thrombotic, embolic, systemic hypoperfusion, and then the various types of hemorrhagic stroke. I did want to briefly introduce this. This was something that was new to me, researching this topic. This is the TOAST classification for ischemic stroke. It really classifies stroke more based upon the cause, and for the hospitalists and the neurologists is good for the treatment and prevention going forward. So it breaks it down into large artery atherosclerosis, cardioembolism, small vessel occlusions, aka lacunar infarcts, stroke of other determined etiology. This would be the more rare syndromes, things like maybe a vasculitis or a dissection, and then stroke of undetermined etiology, which would include a negative evaluation, an incomplete evaluation, or an instance where you might have two or more causes identified. And in the emergency department, this really isn't going to change our management. I mean, whether or not somebody's having a thrombotic stroke or an embolic stroke, we're still going to treat it similarly. But I'd hope to talk about TIA at a later time too. When you're risk stratifying somebody with a TIA, then you really need to get more into like what might be causing it, because that's how you're going to, that's what's going to dictate their prevention and their treatment going forward. And a few of these things might be a little bit useful to us in the emergency department. For instance, the lacunar infarct, if you can identify like a clear lacunar syndrome, you can be pretty confident that they don't have a large vessel occlusion by definition and that they're not going to be a candidate for any kind of endovascular therapy. So like I said, they're lacunar infarcts. These are those small non-cortical infarcts that are caused by an occlusion of that single penetrating branch artery. This is going to be deeper in the brain, the basal ganglia, internal capsule, and pons. This is really important. This is something that, you assess a lot of stroke patients, but I didn't really, it took me a while to like really kind of step back and realize that these lacunar infarcts have absence of these cortical symptoms, these higher level symptoms. So if you see somebody with cortical symptoms, I mean, you can presume it's a little bit larger stroke, and certainly it's no longer a lacunar infarct. So this is going to be aphasia. We all know what that is. Agnosia. That's the inability to process sensory information. That's the person who can't recognize, what an object is, despite the fact that they have like intact vision and speech. Neglect, apraxia. I mean, we're not really often assessing for this in the ED, but this is like the inability to carry out tasks. It's a inability or a loss of motor planning. So this is like, you ask somebody to mime combing their hair, and even though their hand works, and they can hear you, they can't do that. They can't perform that task. You can ask them to like mime combing their hair, mime brushing their teeth, or do a simple task like fold a piece of paper in half and put it in an envelope. And then hemianopsia. So there's 5 lacunar syndromes. The pure motor and the pure sensory ones, I think, are the ones that we're most familiar with and the easiest ones to recognize. There are three others: a sensory motor, ataxia-chemiparesis, and dysarthria clumsy hand syndrome. And I wouldn't expect us to really characterize these in the emergency department, but if you see this, it might ring a bell to you. Sensory motor is just what it sounds like. They have sensation and motor involvement with no cortical involvement, no higher level symptoms. Ataxia-chemiparesis, they'll have unilateral weakness and then some limb ataxia that's out of proportion to their motor deficit. And the dysarthria clumsy hand syndrome, facial weakness, dysarthria, and then just a little bit of upper extremity weakness and clumsiness. So if you see one of these lacunar infarcts, it might help you in guiding your disposition, knowing that they don't have a large vessel occlusion and they're not going to be a candidate for EVT, but they are certainly still a candidate for IVTPA. So this is what we do in the emergency department when we assess stroke. No assessment would be complete without the ABCs, but after the ABCs have been dealt with, we're going to rule out stroke mimics. This is something we do every day. I'd say like 90% of the people I see that are called in as a possible stroke are not really a stroke. It's just altered mental status, overdose, they're drunk, they have hepatic encephalopathy or something like that. They're not having a stroke. They don't have anything focal. Just remember that when you're diagnosing a stroke, focal symptoms. The timing of onset, super critical when determining reperfusion strategies. I like to assess them right away for contraindications to thrombolysis, because this really dictates to me, okay, like they're not a TPA candidate, but I still need to get them out and get them shipped somewhere else if they have a stroke of a certain severity. We want to determine the severity in the NIH stroke scale in the guidelines. It's still the preferred stratification tool. Determine if hemorrhage is present. This is really easy. Get a CT. The last two are, what keeps us up at night. Decide if reperfusion is warranted, and then dispo the patient. This is, can be very complex at a shop like ours. When I, chose this topic, similarly why I chose to talk about STEMI a few years ago is that when we're in residency and we train at big centers, treating somebody with a STEMI and a stroke is like the easiest thing possible. You're like, okay, they have a STEMI, page out the code STEMI, and like a bunch of people descend upon the patient and they take them away. And unless they arrest in the emergency department, you don't really have to do anything. And the same with the stroke. You're like, yep, this patient's having a stroke, code stroke, order a head CT, and it's like, wipe your hands of it, and it's super easy. But at our facility, I find these cases to be incredibly complicated. I mean, they're super high risk, they're critically ill, they could die right in front of you. You're assessing them for, very complex and, therapies that have a high risk to them. And, it's a big deal to put somebody on a helicopter and like fly them to Reno, especially when they get there and they don't have anything done to them. So that's why I wanted to talk about this and hopefully shed a little bit of light on this topic for you guys. Like I said, we're going to talk about, or I'm going to kind of frame this through these guidelines that were published in 2018. So let's get right into it. I'm not going to talk about the studies of telemedicine, but they did say in the guidelines that telemedicine and telestroke evaluations of acute stroke patients can be effective for TPA eligibility. This one to me is really important. What is a major stroke and a minor stroke? Like, what is a stroke that we would potentially treat? There's really no clear definition. If you want a number, most references that I saw looked at a stroke scale of 4 or greater as a major stroke, 3 or less a minor stroke. I will say that I like to think of this as more functionally, like, do they have something that's going to be potentially disabling and really devastating going forward? So I think anybody, and this isn't just me saying this, like the guidelines say this too, complete hemianopia, severe aphasia, any neglect, any significant weakness, like limiting effort against gravity, and the inability to walk, those are people that we should consider for reperfusion. But if you want a number, 4 or greater. Imaging, so nothing has changed too much here for us, at least at Barton. The non-contrast head CT is still the preferred imaging modality of choice. For your patients that you're assessing for TPA, it's the only thing you need to order still. They did say specifically in the guidelines that multimodal CT and MRI, the more complex studies, including perfusion imaging and angiography, should not delay administration of IV TPA. So if I have somebody who I really think is a TPA candidate, I'm only going to order a non-contrast head CT and kind of sort it out from there. I did want to talk about early infarct signs on CT. We all know that CT is not a very sensitive tool for determining the presence of acute stroke, at least radiographically. But you might see the radiologist call these early infarct signs in the CT, and it's kind of important to at least recognize what their significance is. One review I saw said that the prevalence of any sign was 61% within 6 hours. In my experience, it's a lot lower than that. I don't see our radiologists, especially our Nighthawk radiologists, calling these things very often. But you might see this. So the hyperdense vessel sign, the hyperdense MCA sign, parenchymal hypoattenuation. This is the darker color to the tissue, kind of synonymous with edema in the tissues. And then various things that describe sulcal effacement and just some localized edema there. So the hyperdense vessel sign is, if you see this, at least you can recognize that it's most commonly seen in the proximal MCA. If they mention something about a Sylvian dot sign, you're going to see that in the distal MCA. It is very specific for MCA occlusion. It's by no means sensitive, but it is very specific. So if you seed it or you get a radiology report with it, you can be fairly certain that the patient has an MCA occlusion. The absence of it means absolutely nothing. This is really important. It is not linked to outcome, and it is not a contraindication to thrombolysis. So don't let it scare you. If you see it, and I imagine if you see this, the patient also is going to have a really high stroke scale, and it's not going to be you're not going to see a hyperdense MCA sign in somebody who's got a little bit of numbness on one side of their body. So just a few pictures here. You can see the hyperdense MCA on the right there. In this image, you can see it on the left, and then that's a picture of that Sylvian dot sign. That's like an M2 occlusion, M2 branch of the MCA. This is pretty subtle, but this is actually on the patient's right. Oh no, I'll have to come out here. So this insular ribbon here is wide open, whereas here it's just kind of tight. This is some localized edema in that area. This is the big one, cerebral hypoattenuation, black brain tissue. This is a more ominous sign and the one that's a little bit more difficult to deal with. I'm only going to talk about this briefly, but this is the aspects score. This actually quantifies early ischemic changes on CT. The A stands for Alberta, came out of Canada. I don't know what the rest of it stands for. Basically, they grade you 1 to 10 different areas on the CT. If you have a 10, that's a good score. You have no early ischemic changes on a CT. If you have a 1, you have a tremendous number of early ischemic changes on a CT. It's not associated with a statistically significant modification in the TPA treatment effect, but I will say that if you have somebody with an aspect score of 1, that person probably has a much worse prognosis. This really doesn't mean a whole lot to us in the ER, but it's a little helpful to at least know what it is when you read these studies, especially the studies about endovascular therapy. So if you see these early ischemic changes, just remember that they're not a contraindication to TPA. This is really important. Minor early ischemic changes, anything short of large areas of hypoattenuation, are not a contraindication to TPA. Now, this hypoattenuation thing is a little bit more muddy. These are quotes from the guidelines. So there remains insufficient evidence to identify a threshold of CT hypoattenuation that affects treatment response to IV alteplase. So there's no number 40% or 45% or whatever at which you can no longer proceed with TPA. That being said, they didn't define what this is, but they said, quote, extensive areas of clear hypoattenuation are still a relative contraindication to TPA. So I know that's clear as mud. What I would use is this, a few studies like the ECAS studies, they excluded patients with a baseline CT that had hypoattenuation of more than a third of the MCA territory. So I think that's a decent rule of thumb. If you see somebody with hypoattenuation that is more of a third of the MCA territory, I think you can pretty safely call that an area, or that you could call that extensive changes, and you could, justify withholding TPA. If you see a CT like this, though, I think it's reasonable to withhold TPA on that patient. But if you want to make it simple, these early ischemic changes are really not a contraindication to TPA, and they're certainly not an absolute contraindication to TPA. So I think that you can proceed with them, or can proceed with TPA pretty confidently, as long as the head CT doesn't show anything, doesn't show any bleeding, or some kind of mass or something like that. If you want to get a little more detailed, if you see really extensive areas of hypoattenuation, you might want to consider withholding TPA, because that person has a horrible prognosis to begin with. CTA, this is kind of a big deal here as far as, when do we do it? Do we do it before we transfer? Do we do it after we transfer? It's really recommended for patients who might qualify for endovascular therapy. It's a good test. It has really high sensitivity and specificity compared to conventional angiography. It really shouldn't delay IV TPA. I do like this. In the guidelines, they did say specifically that you can proceed without getting a creatinine in patients who don't have prior renal impairment. And, unless the patient has severe renal impairment, for me, not on dialysis, I'm doing the CT anyways, if I think it's indicated. Now, before or after transfer, we're going to get into this a little bit. My thought on this is, if the patient's a clear TPA candidate, I'm probably not going to get a CTA, because, or I should say, if the patient's clearly getting transferred regardless, they have a major stroke with serious deficits, 2 hours of onset, I'm going to assess them for IV TPA, but that person's leaving no matter what. I'm just going to defer it to the receiving center, because they're also going to do a perfusion study and everything else down the road. To me, it is useful in these more muddy patients, the ones who you are not really sure what's going on, or you're not really sure if they need to be transferred. At least if you do a CTA and there's no large vessel occlusion, you've kind of taken that out of the equation, and you know that the patient's not going to get, at least not going to get endovascular therapy going forward.
Like greater than 6 hours since symptom onset might be a good patient to do an angio here, so you don't send everyone up to the
Correct. Although there was, in the last 2 years, were 2 studies for EVT published that went out to 18 to 24 hours. So that
right. Well, that's the question. Do I transfer everyone who's had a stroke in the last 24 hours, or do maybe I risk stratify the ones that are greater than 6 hours and save Renown some receiving?
No, that's reasonable, but that's a
one thought.
And I can understand too the hospitalists being wary of admitting a major stroke, even if it's 8 hours, who has significant deficits. Yeah. I mean, somebody with a little bit of numbness and maybe minimal motor weakness, who's 15 hours out with a negative CTA, yeah, we can probably keep that patient at Barton. But the person who can't talk and is paralyzed, I'm sending that patient personally. So, can LVO be detected clinically? The guidelines essentially say no, not really. A higher NIH can be predictive. Clay and I were talking a little bit earlier about this VAN score. I mean, there is this score that incorporates motor weakness with any kind of higher level symptom, any kind of cortical symptom. It's visual, aphasia, and neglect. So basically, if you have somebody with significant motor weakness and one of those cortical symptoms, they have a higher probability of having a large vessel occlusion. I think that intuitively makes sense. It doesn't really add a lot to my assessment of the patient. I didn't really cover it here because I don't think it's really ready for prime time, but there's really no clinical assessment that can definitively rule in or rule out an LVO. You just need to get imaging if you're concerned about it. We all know that MRI is more sensitive than CT for detecting early infarction, although 90 to 92%, you're going to miss a few with MRI. It's by no means 100%, just remember that. Again, to me, MRI has no utility at all in the real acute hot stroke. It's very useful in these borderline cases for me in the emergency department. The dizziness, and you're not really sure, the vertigo, I should say, and you're not really sure if it's central or peripheral, or the vague symptoms, like just the vague hemi-numbness or some other unusual symptom. You're not really sure. It's not clearly a stroke. I think that's where MRI is pretty useful for us. MRA is pretty much just as good as CTA. If you're going to send them over for an MRI to rule out a stroke, it's probably not a bad idea to do an MRA of the head and neck for further risk stratification. I mean, gosh, if you got somebody who comes in with like a TIA, if you do an MRI and MRA of their head and neck and they're not in atrial fibrillation, I mean, you've kind of done most of the risk stratification already. I'm certainly not advocating that we need to be doing this on all of our patients in the ER, but like we understand that at CVMC there may not be a bed, or it's you might just want to like, you know, bang it out and get it done and just send the patient home instead of admitting them for a number of reasons. So this to me is where like the MRI and MRA are more useful. CT perfusion, we're not doing it here, so I'm not going to say a whole lot about it. It can estimate the size of the ischemic core versus the at-risk tissue, like the so-called penumbra. Really, it can risk stratify people who might be a candidate for TPA or EVT later in the time course. But, you know, for us, we're not doing this here, so just realize that it's out there and that it really can help further, like, it can further determine who's a good candidate for specific therapy going forward, and who is like, you know, if the CT perfusion has a really unfavorable, score, you know, the patient might not get anything further. If they have a huge infarct and like no at-risk tissue around it, you know, they might just be done and they're just going to have to recover, you know, in the rehab facility. But if they have a very small ischemic core and a really large at-risk penumbra, that person might be a candidate for TPA or EVT even outside of the window. Certainly not at our facility, but at these more advanced stroke centers, they are doing this. And the same thing can be done with MRI. So do you need to do a chest x-ray? No, unless they have cardiopulmonary symptoms or you suspect it. Like, you do not need to get a chest x-ray routinely on stroke patients. Labs, this to me was kind of cool. I mean, you know, the platelet count and the INR and all that stuff and the glucose are exclusion criteria on the TPA list. But they said that a glucose is really the only thing that's mandatory before they get TPA. You should await labs if you suspect that there might be an abnormality. But in an otherwise healthy person who has no liver disease and they're not anticoagulated, you don't really need to wait because, I mean, we all know that those patients are not going to have abnormal coagulation parameters. There was a study here that, you know, shows that normal coagulation parameters can be predicted by 3 questions. Did they take an oral anticoagulant? Are they on heparin? Or are they on dialysis? If the answer is no, they probably don't have any kind of coagulation abnormality, and you can proceed with TPA before getting the labs back. The only thing you need to do is a glucose. I still like to get the labs off before I send the patient to CT really quickly. That way you have them instead of waiting later. But, you know, if you can get the patient like to CT really quickly and get them back, and you think they're a candidate, I wouldn't delay the administration of TPA, you know, waiting for their PTT to come back when they're not on heparin. All right, so let's talk about interventions. Quickly, we're going to talk about, just to understand some of these studies, I do want to briefly mention the modified Rankin scale. This is by far the most common scale to kind of assess stroke patients' outcomes. I put this line there between 2 and 3 because a lot of these stroke studies are going to have dichotomous outcomes, like a modified Rankin score of 0 to 2 or 3 to 6. The reason they do that is because somebody who has a score of 2 is still technically functionally independent. They might have a little bit of disability and they might not be able to do what they were doing before they had their stroke. They might not be able to go golfing, but they can still live on their own. Whereas somebody with 3, an MRS of 3 requires help. So that's why a lot of these studies are going to have this dichotomous outcome. Some of them will look at patients with an MRS of just 0 to 1, some of them 0 to 2. So head positioning, if you've wondered, doesn't really make a difference. They actually studied this in 11,000 patients in the New England Journal of Medicine in 2017, and there was no significant difference in the head positioning.
I'm still raising. Patient satisfaction scores.
Similarly with oxygen, well, you know, TBI, I mean, head positioning probably makes some difference, you know, the 30 degrees, but not for stroke patients, at least not that the evidence can support. Same thing with oxygen. I mean, the same thing has been demonstrated in MI, STEMI, ACS. Like, if they're not hypoxic, they don't need oxygen. They've done the same study in stroke patients, published the same thing in 2017, like more than 8,000 patients randomized 1:1 to get continuous oxygen, nocturnal oxygen, or just oxygen is clinically indicated, and there was no difference in the outcome. Hyperglycemia, this is going to be more pertinent to our hospitalist colleagues, but just kind of moderate glucose control is recommended. You don't need to do super intense glucose control. There was this big study published last year in JAMA, more than 1,000 stroke patients with hyperglycemia randomized to get like intensive treatment on a drip versus just standard treatment with like a sliding scale trying to keep them less than 180. And there was no difference in the primary outcome. And obviously the intensive group had more hypoglycemia. So just normal sliding scale insulin's fine on these patients. They don't need to be on a drip. It is recommended though that in the ED, if you like, if you're treating a stroke patient and their glucose is 400, you should give them something for it. It really is linked to worse outcomes down the road, persistent hyperglycemia. People always ask about blood pressure. Not a whole lot has changed, at least in the guidelines. The threshold for TPA is still the same. This to me is an important number to know. It's 185/110. If you can't get it to 185/110 without if you can't get it to 185/110 with only like kind of mild intervention, then the person would be excluded for TPA. What is a non-aggressive intervention for blood pressure? They said like 10 to 20 of labetalol. You can repeat it once or put them on a nicardipine drip, kind of standard numbers. And if that doesn't control their blood pressure to less than 185/110, they're excluded from getting TPA. Personally, me in the ED, I use labetalol because it's just like quick push. Patients come in, their blood pressure is 210/115, 20 of labetalol. If that doesn't do it, maybe 10 or 20 more. And if that doesn't do it, like they're not getting TPA. But
seriously, I mean,
yeah.
People are very scared.
Well, if they're in pain, treat their pain. Yeah, all that stuff. Although I wouldn't give them any more than one of Ativan, not to like.
Just don't forget that
Make
anxiety is going to almost universally be present, and many times you give them.
And we've all seen this. The blood pressure often just comes down on its own.
Yeah.
But an admission blood pressure alone is not a contraindication of TPA. Like you can treat it and still give them TPA, but they just don't want you to have to treat it aggressively. So 2 doses of labetalol is not considered aggressive. Anything more would be. If you give them TPA, you should try to keep their blood pressure less than 180/105. And the recommendation is still for non-TPA patients to only treat them if their blood pressure is more than 220/120. This is from the guidelines. There was a large meta-analysis in 2015 showing no effect on multiple outcomes with acute blood pressure lowering. That being said, this was actually just published last year, the MAPIS trial. It's only 200 plus patients, so I don't think this study is practice changing, but I think it would be practice informing. They were randomized to 3 different blood pressure ranges in the first 24 hours. These are patients who are not getting TPA. There was no difference in the good outcome, although there was a significant trend towards a better outcome in the patients who had the lower blood pressure numbers. And the patients who had the higher, whose blood pressure was allowed to ride higher, had more intracranial hemorrhages. In the post hoc logistic regression analysis, group 2, the blood pressure of 160/180 seemed to do the best. Again, I don't think this is practice changing. I don't think you should aggressively treat all these patients. But in the next set of guidelines, you might see something reflecting this, that you might want to lower that blood pressure just a little bit. In the ER, I don't think it really changes for us. This is probably more for the hospitalists. And I imagine you guys don't just let the blood pressure ride like more than 220/120 for 24 straight hours, huh?
220/110?
Yeah.
Yes, in the acute setting. What's that? In the acute setting, yes.
What is the acute setting, just out of curiosity?
I think it depends on
24 to 48 hours, or?
I think it depends on how big the stroke and
Yeah.
the disability. So truly, sorry to interrupt, but
No.
Essentially, each patient is different, each stroke is different, and there's a lot of flexibility, I think, in the blood pressure management. So.
I will say that, the guidelines, there's no clear indication that you have to treat a blood pressure of less than 220 over 120. If you want to make it easy, that's fine. And whatever you do, I wouldn't be like, you don't want to dump these blood pressures quickly with like a, big slug of IV hydralazine or something like that. Treat it gently. But if you're considering TPA, you do need to get that blood pressure down into that range because, if they have a complication and their blood pressure was riding high, that's going to be an issue. So, the summary of these other interventions, you don't need to give them oxygen unless they're hypoxic. The head of the bed doesn't really matter. You can go ahead and treat their blood sugar, but standard control is fine. And I think we don't need to rehash the blood pressure thing. We just talked about that. So what about aspirin? We're going to talk now about some medications. The guidelines say that you can hold it for 24 hours if you're giving TPA. It's really unclear what to do if they're getting EVT. Basically, if the patient's going to be transferred, I just wouldn't give aspirin and let them figure it out there. That being said, if you have a patient who's not a candidate for reperfusion and they don't have a hemorrhage on their CT, it's reasonable to start it. And for the bigger strokes, aspirin monotherapy is going to be the preferred therapy going forward until the workup's completed and you kind of figure out what the cause is and what their long-term treatment's going to be. I did want to touch on this. This, again, isn't that pertinent to us in the emergency department. It might be if you're risk stratifying TIA patients because you don't have beds, but this dual antiplatelet therapy for minor strokes and high-risk TIAs. So there were two studies, this CHANCE study and the POINT trial, within the last 7 years or so, that both evaluated and support this dual short-term antiplatelet therapy, aspirin Plavix, versus aspirin alone for minor strokes and high-risk TIAs. So this would be a stroke with a stroke scale of less than 3 or a TIA with a ABCD2 score of greater than 4 or greater. So high-risk TIAs and minor strokes are basically treated the same going forward. There were more than 9,000 patients in these two studies, and they had a 1.5 to 3% reduction in stroke risk at 90 days. Most of that benefit was seen in the first 21 days, which is why most of these patients are only going to get the therapy for 3 weeks. So basically, you give them aspirin, you give them Plavix, you can go ahead and give them a loading dose and then just kind of the standard low dose going forward. This is going to be 21 days for most, maybe 90 days for patients with large vessel intracranial atherosclerosis, like M1 branch of their MCA atherosclerosis, but 21 days for most people. But this could come into play with us in the ED. I have to risk stratify patients at CVMC with TIA because we don't have a bed or they don't want to go anywhere. And you're like, okay, well, I'll get a carotid Doppler, might as well while you're here and send you home. And if you're comfortable or you feel comfortable doing it, you could, if they have a higher risk TIA, you could put them on 3 weeks of Plavix in addition to aspirin. Just assess their bleeding risk. There's no role for anticoagulants acutely, not like heparin, Xarelto. Acutely, just throw them out the window. Long term, it's a whole different story, but acutely, no role. So let's talk about TPA. Here's our MRS again. Just remember, most of these outcomes, an MRS of 0 to 2 versus 3 to 6 is kind of your dichotomous outcome. And when I talk about these studies, I'm only going to talk about the primary outcome. I mean, there's so many post hoc after the fact analyses that have these super complex statistical things that I have no idea how to interpret, these ordinal analyses and everything like that. But the numbers I use when I'm consenting patients are these primary outcome numbers, like the number needed to treat and the number needed to harm. And I think those are pretty clear when you look at these studies, and they're reasonably consistent. This to me took me a while to figure this out, but you see this symptomatic intracranial hemorrhage, what's the rate of symptomatic intracranial hemorrhage in your TPA or EVT study? So there's actually two definitions. I wasn't really aware of this. It's why does one study report an ICH rate of 2% and most studies report a rate of 7%? That doesn't make sense. Well, it's because there's two definitions. So the NINDS study, which is what most people quote when they talk about TPA, it's I think the most well-known study. They defined a symptomatic intracranial hemorrhage as any hemorrhagic transformation that temporarily worsens their neurologic status. Even if it's very transient and minimal, it would still be called a symptomatic intracranial hemorrhage by that definition. Some people would argue that it's over-inclusive, and it may not really reflect a patient-oriented outcome. That's debatable, but if you define it this way, you're going to see symptomatic intracranial hemorrhage rates with TPA of like 5 to 7%. And then a couple other studies, ECAS-3 and SITSMOST, they defined it as a hemorrhage that caused a clinical worsening of 4 points or greater on the NIH stroke scale. And people would argue that this might be, more indicative of like something that would cause a long-term problem, something that might be more patient-oriented. And this is going to be generally around 2% in these studies. So I didn't, come here to debate which definition you think is more appropriate, but when you see these different numbers, this is why. So the guidelines, if you want to just sum it up right here, the guidelines say TPA is a strong Class 1 level of evidence A recommendation, like the highest recommendation you can give. So the horse is out of the barn, the ship has sailed, TPA, it's in, despite a lot of the skepticism from people in emergency medicine. We'll talk a little bit about why the skepticism might exist. I'll say right now that I think the TPA is good in the right patient. I believe, I've looked at these studies and I think it is the right thing to do in the right patient. But there is, I think, some reason for skepticism. But it's a Class 1 level of evidence A recommendation. So if you don't want to think about it anymore, the AHA and the ASA have, come out and say that, like, by the way, this is within 3 hours. I should have clarified that. But these are patients within 3 hours. It is a strong recommendation that you need to consider them for IV TPA. All right. So why the skepticism? I don't want to do too much of a deep dive here. I totally got into the wormhole when I was preparing this study. But I'm going to just summarize some of the negative studies. First one, ECAS-1, 1995. This was an RCT of like more than 620 stroke patients who were randomized within 6 hours. This to me is a big deal because a lot of these patients got treated after 3 hours. They had a lot of protocol violations, like more than 100 patients, so more than 15% of their patients had protocol violations. For the EBM nerds, in the intention to treat analysis, there was no difference in the primary endpoint. This was also a little unique in that they used a median modified Rankin scale instead of this dichotomous outcome that like all the other studies going forward used. And the 90-day mortality was increased in the intention to treat analysis. Now, the per protocol analysis did show a little bit of benefit. Remember that intention to treat includes people into like what group they were randomized in to begin with, regardless of how they were treated. It's a little bit more, I think, authentic and a little bit more realistic, whereas per protocol analyses are a little bit more idealistic and may not reflect real world treatment. So most EBM nerds are going to accept the intention to treat analysis as like the gold standard. So there was no difference in the primary endpoint in the ITT analysis. There was an improved MRS in the per protocol analysis, and there were more hemorrhages, of course, there are in all these studies, that's not a surprise, and probably an increased mortality. Why is there a reason for optimism looking at this study? Well, if you change the outcome to this dichotomous MRS outcome of 0 to 1 versus 2 or greater, there was an 8% absolute risk reduction benefit for TPA. And this to me is the big deal. Like, they included patients up to 6 hours. Only 87 of the 600 patients got treated within 3 hours. So when people like dog these studies, I think you have to realize that like most of them don't reflect how we're really treating patients. The 0 to 3 hours to me is by far like the best evidence for treating people with TPA. ECAS-2, also ultimately a negative study. A few years later, more than 800 stroke patients. They used this dichotomous modified Rankin scale as their primary outcome. There was no difference in the primary outcome in these patients. Now, if they changed their outcome a little bit from 0 to 2 instead of 0 to 1, there was a difference. And, no mortality difference, and there was higher rate of hemorrhage. All these studies basically are going to show a small benefit in the 0 to 3 hour group as far as function. They're all going to show no mortality, and they're all going to show no difference in mortality, and they're all going to show an increased rate of intracranial hemorrhage if you really want to.
In this study, they had a pre-planned subgroup analysis of 0 to 3, and there was still no difference. Which is interesting because that was the big ticket for IST, but I don't want to get into that. But that one was...
Well, only 150 of their 800 patients were randomized within 3 hours. So, I mean, again, like to me, this study's just doesn't really look at like the question that we want to know. Like, does TPA benefit patients within 3 hours? So IST3, another negative study. This is an open label study. Again, for the EBM nerds, open label, right? So everybody knows like who's getting the placebo versus the drug. Theoretically, with human bias, it should significantly favor the drug as opposed to the placebo. They randomized people within 6 hours, but they had a lot of old patients and they treated patients within 6 hours. So again, it's like, how applicable is this to us seeing patients at Barton? I'm not really sure. There was no difference in the primary outcome. You know, people purport this mild favorable shift along the ordinal analysis. So this graphic kind of indicates that, like you know, if looking to the right is a bad outcome and looking to the left is a good outcome, it very, very, very gently shifts the curve to the left. It's not terribly significant if you ask me. Just like looking at that graphic, that really sums it up to me. That, you know, it's minimal at best effect on this like secondary ordinal analysis. But again, like, why is there a reason for optimism looking at this study? Well, again, they included patients up to 6 hours, and they did find a benefit in the 0 to 3 hour group, subgroup, about an 8% absolute risk reduction, so a number needed to treat of 12. I'm just going to say the same thing about Atlantis B. Same thing. I mean, they were studying patients 3 to 5 hours. There was no difference in their primary outcome. More symptomatic intracranial hemorrhages, trend towards an increased mortality. Why is there reasons for optimism? Well, you know, they had a few patients who got it within 3 hours, and in their very, very small group of 61 patients, they had a benefit within 3 hours. So all the ECAS 1 and 2, I should say, IST3 and the Atlantis studies summary, none of them found a difference in the primary outcome. They were all negative studies. These secondary outcomes and post hoc analyses showed some benefit, especially in the 0 to 3 hour group. More ICHs, no surprise, and probably similar mortality. So why did they give this level 1 grade A recommendation? And now we're going to talk about the positive studies. And this to me is the one that, you know, if you're going to kind of know any stroke study, this is the one, the NINDS study. This was published in 1995, an American study. This is, you know, a landmark study in medicine, all of medicine, not just neurology. So they randomized 624 stroke patients to receive TPA versus placebo within 0 to 3 hours. They had 4 different outcomes, but they were all pretty similar, like a dichotomous outcome of like a good outcome versus a bad outcome. And they showed a significant improvement in all outcomes measured at 3 months. And across the board, they had a 12 to 15% absolute improvements in these primary outcomes. So if you use the modified Rankin scale as kind of the gold standard, 39% of patients who got TPA had a good MRS at 90 days versus 26% of placebo. That is a 13% absolute risk reduction, right? So if you divide 100 by 13, that's how you get your NNT. So that means you need to treat 8 patients with TPA to get 1 good outcome that wouldn't have been there otherwise. This is the number I personally use when I consent patients. Like 1 in 8 people who get this drug will have a better outcome than if they didn't get the drug. And 1 in somewhere between 15 and 20 are going to have a side effect of the drug. Their rate of symptomatic intracranial hemorrhage was 6.4 versus 0.6%. That's a number needed to harm of about 17, and there was no mortality difference. So again, an NNT of 8 and a number needed to harm of 17 to get a symptomatic intracranial hemorrhage. This is the more inclusive definition of a symptomatic intracranial hemorrhage, though. So some of these hemorrhages, admittedly, might be small, but if I'm not mistaken, like somewhere between half and 2/3 of the patients who had an ICH in this study died from the ICH. But, just remember too, you're not necessarily killing more patients by giving them TPA. The mortality rate between the drug and the placebo is the same. And they have done these pooled analyses when they just look at like the 0 to 3 hour patients, and there is a favorable odds ratio for the patients who were treated within 3 hours. And similarly, they found about a 5% difference in the symptomatic intracranial hemorrhage rate. This SITSMOS trial, this really just kind of supports that you can do this in small hospitals like Barton Hospital. They looked at this is an observational study, it's not a randomized control trial, but they looked at more than 6,000 stroke patients treated in almost 300 different hospitals, 50% of which, like us, have little experience in using TPA. And basically, their outcomes were similar to pooled values from prior RCTs. And they determined that, certainly people in docs in small hospitals like ours are not necessarily doing this worse than they are in these academic centers. That was their conclusion by the SITSMOS study. And there was a big meta-analysis published in 2014 that showed very similar numbers to what I've been kind of showing you guys here, that treatment within 3 hours led to a favorable outcome in 33% versus 23%. So they got an NNT of 10, and they got an NNT of 18 in this meta-analysis. So this is another number you can use, like somewhere, the NNT of 8 to 10 is going to be your benefit, and the number needed to harm, 17, 18, 20 or so, depending on what study you look at, is going to be your number needed to harm. So the trend does seem to be, I shouldn't say the trend, but there really does seem to be benefit as far as functional outcome in the 0 to 3 hour group, with a better number needed to treat versus the number needed to harm. All right, so what about the 3 to 4.5 hour window? I kind of glazed over it, but that meta-analysis did not show any difference in the 3 to 4.5 hour window, but this study did, and this is essentially the support for the 3 to 4.5 hour window. This study, ECAS-3, published in 2008. Same thing, TPA versus placebo for patients who presented within 3 to 4.5 hours. They did have a few more exclusion criteria. Older patients, they did exclude patients who had a CT hypodensity of more than a third of the MCA distribution. They excluded really high stroke scales of 25 or greater, and they excluded any oral anticoagulant use. They had this primary outcome of an MRS of 0 to 1 in 90 days, and the results did favor TPA for the primary outcome. They had a 52% versus 45% favorable outcome. That is a 7% absolute risk reduction. That is an NNT of 14. They used the less inclusive definition of an intracranial hemorrhage, and they got about a 2% difference. So that would be a number needed to harm in that study of 50. But when you use the NINDS definition, they got 8 versus about 3.5%, so a number needed to harm at 23. If you just want to keep the numbers similar between the two studies, that's why I used that number needed to harm instead of 50. It would be 50 for the more strict definition. It would be 23 for the more inclusive definition. But if you want to kind of compare apples to apples, this ECAS-3 to NINDS, that's how I got those numbers. So it still favors TPA in the 3 to 4.5 hour window, but a little bit narrower benefit, a number needed to treat of 14, a number needed to harm of 23. For what it's worth, the guidelines do support TPA between the 3 to 4.5 hour window. They give it a strong level evidence of B recommendation. So, again, we can nerd out on this stuff all day, but really what it comes down to is that the guidelines support it, and you really need to consider patients for it. And I just don't know that you saying, oh, I've read the studies and I don't agree with it, I'm not going to offer it to the patient, is going to stand up very well. Clay and I have had this discussion a lot. I mean,
I do want to point out something about ECAS-3 that this is actually true of a couple of these positive RCTs, and it is really EBM nerd. And I think Mike's right. I think when you start EBM nerding in the stroke literature, you start to find things that don't smell right. And but I think the more important message is one that has 25 plus years of experience and has led to these very strong guidelines. I do not think that TPA has a class 1A or a 1B based on the EBM nerdy stuff. That's my personal opinion. here's an example, like they did fragility index calculations on these studies, and that's a fragility index is sort of like how many patients would have to end up in the other group outcome-wise to make it non-statistically significant. Does that make sense? So it's a bit of a mathematical model, like a hypothetical model. And so in the ECAS-3, for example, which is the only study that's shown any benefit for IVTPA for between 3 and 4.5 hours, the fragility index was calculated as 1. So if one patient was moved from the positive outcome to the negative outcome group, then the trial would no longer have been statistically significant. And I think that's worth knowing, because, and that's why this not had the 3 to 4.5 hour has not received an FDA approval. But nevertheless, I think that these are interesting points for those people who are sort of interested in sort of the math behind some of this. But again, the horse is sort of left the barn, so I think that Mike's point is far more important clinically.
And I still think that, in the 0 to 3, I mean, looking at this, I think that would actually be hard to argue against giving the drug at this point. I mean, even in the negative studies, all the subgroup analyses in the 0 to 3 hour groups seem to show benefit, and there are, a couple of studies that do show benefit in that group, like large randomized control trials. And I think there is something to be said just for clinical experience. Like, I imagine that if all these doctors the world over saw that they were just killing lots of different patients with giving this drug, they would kind of stop giving the drug and maybe question what they're doing. I mean, I don't think everybody is in the pocket of big pharma. Certainly not people who are in the trenches working clinically in the ICU and in the emergency department. So I'm for it personally, but I did want to just kind of talk a little bit about the data, because it's not overwhelming like the TPA for STEMI data, where they have 60,000 patients in multiple studies that all show almost the exact same benefit, study to study to study. It's very, very clear in that kind of instance, whereas in stroke, it's a little more muddy in my opinion, but I still think you should do it. I personally do it, and I do it without reservation in the right patient. If there's any contraindication, you got to be super strict about this. So again, the number needed to treat somewhere between 8 and 10 in the 0 to 3 hour window, and the number needed to harm 17 to 18, maybe 20 if you're an optimist. Those are the numbers that I consent patients with when I consent them for IVTPA. So the indications, who should you give TPA to? I mean, really anybody with a significant stroke. We talked about major versus minor. They're technically a candidate within 4.5 hours of onset. And if there were more than 18. And of course, I wouldn't expect you to see this list, but there's a long list of contraindications, and totally, this is so important. When you see a stroke patient, get the checklist and take it to the bedside and check it off with a pen. I mean, don't just rattle this off the top of your head. You really have to go and check every single contraindication and make sure that it is not present when you're giving TPA. And there's no possible way that anybody could remember all these contraindications. So take the checklist to the bedside. It's in the file cabinets at CVMC at Barton. If for some reason you can't find it in the file cabinet, you can easily Google this and print it out real quick and bring it to the bedside and seriously just sit there and check it and then document it. I did want to talk about a few things down here at the bottom that are, to me, kind of the most important. I mean, obviously, if they have a brain, tumor, or they're bleeding to death, I mean, you're not going to give them TPA. But this stuff, this is a little bit more nuanced, but really matters. So if they're anticoagulated with an INR of more than 1.7, they are no longer a candidate. Dialysis is not an exclusion, but their PTT needs to be normal if they're on dialysis. So if they're on dialysis, you do need to wait for the labs. This is for the hospitalists who might have a stroke in the hospital. Therapeutic doses of heparin, low molecular weight heparin specifically, used to treat VTE, a treatment dose of Lovenox, is a contraindication. But a prophylactic dose is not a contraindication. So if you have somebody who has a big stroke on the floor, if they're just getting their prophylactic dose, it's not a reason to exclude them. This to me took some searching, but I did find this in the guidelines. Aspirin and Plavix are not an absolute contraindication. You should be wary because they do have an increased rate of bleeding in these patients, but it's not listed as an absolute contraindication. So antiplatelet agents alone are not technically a contraindication. There are also plenty of warnings. I will just say that menstruation does not apply. So if like vaginal bleeding, if somebody is having serious vaginal bleeding, that's one thing, but normal menstruation does not apply. Seizure, this is one that to me, seizure to me is in the differential diagnosis of a stroke mimic, and only a minority of stroke patients are going to present with a seizure. So if you get a good story that a patient had a seizure, to me, I'm not giving that patient TPA unless there's some overwhelming evidence, like I did in a CTA or something, and they have an M2 occlusion or a hyperdense MCA sign or something like that. I mean, I'm really wary of giving a TPA to a stroke patient.
That's who we were doing these
Or
static MRI
seizure
on.
patient.
These
Excuse
people
me.
with seizures, coming with seizures that looked like strokes.
Mhm.
That's who we would basically try to take quick CT and straight over to MRI. And my last shot was
That's-
good use for that if the MRI is available for something quick.
I got to say that, I don't know, I'm certainly not I don't have a wealth of experience, nor do I follow every one of these patients up, but I'm just not recalling that many of my seizure patients, I'm not getting the, hey, remember that guy you admitted with a seizure? He ended up having a huge stroke. I don't feel like I'm getting a lot of those calls. So,
If they resolve in the ER, then you either
well, right. That's
release your
reassess that patient, but really be wary of the seizure. It's not an absolute contraindication, but it's a relative contraindication. And that, that's a good point about the MRI. I didn't really think about that, but that might be a reason if you can get one quickly, or, maybe throw the CTA on. I like the CTA in those unclear patients where I'm just not really sure what the hell I'm going to do. Man, is this a stroke? Is it not a stroke? Are they getting better? Are they not getting better? Because if they get better and the CTA is negative, then I can relax. I don't have to put them on a helicopter. But I know. Well, I mean, don't get me wrong. I mean, I'm talking about the kind of the TIA,
Yeah, if they have a dense stroke, they're
No, yeah, totally. I mean, this is who significantly gets better. And I mean,
Are you waiting for the INR to come back, or are you just asking your 3 questions?
so
Is there anticoagulant?
I am
It
not.
doesn't matter. No one's on Coumadin anymore.
Exactly, that's the thing. What do they say
No, I
about
mean some people are valvular.
No, direct. Sorry, if I
What do
wasn't.
they say about DOAX? Yeah.
Oh, did I not say that?
Contraindication.
Yeah.
Yeah, that's what I thought.
Oh, yeah. Sorry. Thank you for reminding me. Yeah, DOAX, NOAX, whatever you want to call them, they are a contraindication. So if they're on Xarelto or Eliquis, no TPA. Now, if they've taken it recently, but I don't have a number for you, 48 hours, 24 hours. But if they're on Eliquis, unless they specifically tell me I'm 1,000% sure I haven't taken it, because it's waiting for me at the pharmacy for a refill for the last 7 days. Maybe in that instance I might consider it, but if they're on it, I'm not giving the TPA person. Exactly.
Yeah.
And we're going to talk a little bit about the dispo, but these are all these patients are every case is unique, and you got to definitely get on the phone with the hospitalist and make sure that they're comfortable keeping this patient. And I'm saying it right here, I certainly wouldn't fault you for asking us to transfer any of these patients who are truly having a stroke. I mean, I think these patients who are rapidly getting better with negative angiography, I think we can keep.
So the previous ICH refers to hypertensive hemorrhages and not people who had TBIs with big brain bleeds?
Correct. Yes. That's actually, I should have mentioned that. That is a great point. Prior intracranial bleeding means a spontaneous. I put that there. It does mean a spontaneous ICH. When you were 18 years old and you wrecked your motorcycle and had a tiny little subarachnoid, that doesn't mean anything. I mean, if they had a major TBI in the last few months, I'd be a little bit worried. But if somebody had a subdural from trauma 10 years ago, that does not mean anything.
That's a great question.
That's a great question.
It makes sense physiologically too, because the major causes of spontaneous ICH are vascular in nature,
Mhm.
either amyloid or aneurysmal, amyloid angiopathy. That's correct. That's the most common.
Hypertensive, probably, yeah. So it's really what you're worried about.
So those patients are more likely to have a vascular weakening that will predispose them to bleeding.
That is a great point, though. I should have mentioned that. Yes, it is a spontaneous ICH, not a traumatic ICH in the remote past. Renown lists these on their checklist. They do subscribe to these additional warnings. These come straight out of the ECAS-3 study for the 3 to 4.5 hour window. And then oral anticoagulants does not mean antiplatelets. So these are, again, like any warfarin use. They actually excluded anybody with it. It doesn't matter what their INR was if they're in this 3 to 4.5 hour window. But NOACs, DOACs, whatever you want to call them, no bueno for TPA. But antiplatelet agents, at least, are not an absolute contraindication. But I would be just a little bit more wary. Just take that into consideration. That might be a good patient if you're not comfortable with just administering the drug on your own. I think that'd be reasonable to give a phone consult. And I will say, I think like we should all be, at least be able to like assess somebody and do a stroke scale and somebody who clearly is a candidate for TPA and clearly has no contraindications. I mean, I think this is just me personally. I know people would argue with me, but I think we can just like give that drug without getting a neurologist on the phone. If it's weird or there's a question or there's like maybe one of these soft contraindications and you're a little worried, then by all means, yeah, go ahead and consult. In my experience, if you go ahead and consult, you're probably going to get the yes. Just like, hey, you call the cardiologist, should I cath this or should we transfer this guy for cath or should I give him lytics? Oh, put him on the helicopter. Like they're never going to say lytics. They're never going to say no. So. So can you predict an intracranial hemorrhage? Not really. This is interesting to me though. This was published in 2012, I believe. They did like this registry analysis of more than 31,000 TPA patients. They had the more strict SITS-MOST definition, the one where you only see like 2% of the time. And they identified 9 independent risk factors for symptomatic intracranial hemorrhage, and the risk factor with the most effect was aspirin and Plavix. Now it's still not a contraindication, but like that's the one to me where I would be a little wary and at least mention it to the patient in the consent. So basically, the older they are, the sicker they are, the bigger the stroke, and if they're on any antiplatelet agents, those are the people who are a little bit more likely to bleed. And they actually, quantified if you have a low risk on this scoring system, 0 to 2. I mean, you have a 0.4% risk of a symptomatic intracranial hemorrhage, whereas if you have 9 or more points, your risk is 9.2%. It has not been validated since it was published, so I don't really think it's ready for prime time. I tried to look it up on my MD Calc app, and it's not there. So just something to keep in mind. But this, to me, kind of reinforced that like aspirin and Plavix thing. This is another one of those instances where it's kind of clear as mud. It's not it's not an absolute contraindication, but it's definitely a risk factor for bleeding. So take that.
The other thing I see there that we can affect is potentially that blood glucose too.
Yeah, totally.
I think in the data sets, when you're doing a retrospective derivation set for a risk prediction tool, you're going to find the people with hyperglycemia are going to be people who have chronic hyperglycemia and chronic diabetes who are going to have vascular insufficiency because of that over time. It's not necessarily that they're acutely hyperglycemic. I don't know if you know what I'm saying, like when you're deriving it.
Yeah, when they're pulling this data, it's probably from a special set of labs, not what you did to give them insulin and then that.
Right, exactly.
Correct.
Exactly. It's more of what happens to your vessels over time with hyperglycemia.
One thing that was also kind of interesting to me is that, and I double checked this, the higher weight patients had a higher risk of bleeding, whereas in the STEMI literature, it's the lower weight patients. Always found that kind of interesting. But with the TNKs that we use, I mean, we do use a weight-based dosing, so maybe that has changed things. But the heavier patients tend to do worse with the stroke. All right, so use a checklist. I mean, I can't really stress this enough. Like, this is one where you got to get the checklist out because you're never going to be able to remember all those contraindications. And I definitely have patients sign a consent, like have them sign it. Whatever, intravenous alteplase for stroke, and have them sign the consent form.
Hold on a second. Before we leave this idea of consent, because some of these people are, they're elderly, there's maybe degrees of dementia, it's hard to
Totally.
understand, kind of thing like that. I mean, consenting is not exactly a simple thing, particularly if you don't have a family member present. I don't know, I guess I'd like to hear what you guys do in that circumstance if you're not certain the patient is understanding what you're trying to explain.
Mm-hmm.
And same with contraindication lists. I agree, it's hard sometimes to actually check if they have all those contraindications or not.
Absolutely. Don't get me wrong. Like,
I think if you don't have a family member there who's knowledgeable and you can't get a hold of one, I personally don't feel comfortable with more with the contraindication part, and I wouldn't feel comfortable with that. And so, in those cases, I just do everything I can to get a hold of somebody who knows it, whether even if it's their primary physician or somebody
yeah,
who has.
I would agree. If
history.
if I can't get any history and I can't get anybody in the horn that give me any history, like what drugs they're on or like when, I mean, then I'm not going to give the TPA. I mean, maybe send that maybe they can like risk stratify them with a perfusion study or something down the road. But and you know, the dementia thing, it's not a contraindication, but I think most physicians are not going to give like TPA to somebody who was demented at baseline.
I'd agree with you about a reliable family member. I mean, unless you have a reliable family member with time of onset and medical history, just don't give. Yeah, I agree with that.
But if the patient's able to give you the information, you know, if they can't like head nods, whatever, yes and no, like, I mean, these patients are so difficult because you have to just drop everything and like focus on that patient alone for at least like, it seems like 30 minutes. And it's really hard to shift back and forth, and these patients are incredibly difficult.
This would be a good time to put a plug in for the AAEM's visual tool. I don't know, have you guys seen that?
Mm-hmm.
That thing is real nice. It basically uses those same memory treatment and too hard.
Yes, that was my, that was an
It's a very, very, very useful thing. Most patients, and this is also evidence-based, like they really respond well to visual tools, and there's a risk stratification tool. I can email it out. But if you Google AEM stroke tool, print it out, take it to the bedside.
That might be worth putting in our stroke packets.
Yeah, we may have.
Yeah,
We used to have that. Yeah, we used to have them in the
Did we?
stroke packet.
I've seen it before. I don't remember being
Anyway, that's a good way to kind of
We can
nail
email
this
as well,
down.
I'll look it up.
So in that train of thought, like, would it be safe to say, or like fair to say to a patient, like 20 cases like yours, or 18?
I think if 20 is reasonable. I don't think you're lying.
2 get better, 17 don't have
My
any change.
opinion
Like,
is-
is that what
In my
you
opinion,
guys?
that's pretty reasonable.
Like,
Yeah, I try to frame it that
I
way.
mean, you may have some medical problems that make your
Yeah.
worsening more likely, such as
1 in 8 patients who get this drug are going to be helped by the drug. They're going to do better where they wouldn't have been better without the drug. 1 in somewhere around 20 patients are going to have a major side effect.
Have an SBT over here.
I always
I
lead.
do too. Like, what do I say now?
I lead with it. This is the most dangerous drug we give in the emergency department. So I lead with that because I really want them to know, like, this is not like, we're not talking about the Z-Pack for bronchitis.
But you say
Um,
you're not giving anyway.
Yes, I mean, it's not, but it's even not like even more invasive stuff. It's not like a lot of like.
It's the most dangerous drug we give in the ER.
Yeah.
You are a candidate to get this drug, which is why I'm discussing it with you. Like, this is a serious stroke. You know, this drug does benefit people as far as like having it, doing better as far as an outcome down the road. About 1 in 8 people who get this drug would do better who wouldn't have otherwise gotten it.
So
But at the same time, this, like, there is a very scary side effect of bleeding in the brain, and like that can be fatal, and that happens about 1 in 20 times. But I think you're a candidate. You know, I think you can. I mean, so I've heard people use that term like, "Would you rather be dead or disabled?" I don't think that's like a terribly dishonest thing to say to the patient, or like you can kind. I think you can kind of say that frankly and genuinely.
I would avoid saying it like that just because then I get the fallout. I don't know.
Well, it is kind of
But-
aggressive.
Yeah. Would you rather be dead or just
Right.
Well, I don't like.
I didn't even say that, but maybe not.
Those words in a way that gave.
That's empathetic.
Yeah.
Well, yeah,
I was
yeah.
gonna
I
say
mean,
that after you're done with this talk, I'll speak to it a little bit, but
Please.
as part of the stuff we're doing, I can create an informed consent that we're all comfortable with, as part of the packet.
some of those visual tools too. I don't want to like. This is the EBM nerdy stuff. Like some of them will say that like 1 in 3 patients benefit.
That's
And that's when you're looking at like that very mild ordinal shift along the curve.
We're also using relative risk on that one. I've seen
Yeah,
that.
it's I know and yeah, the relative versus like right. I mean,
Well, you remember the one that Warren came up with a long time ago, which whether
I
it's
thought was
correct or not.
I thought was not accurate at all.
No,
It was
no,
like
that's what I'm saying, but if you take the vein of that, meaning that
Yeah.
the idea was to give patients the information, and so the numbers that we choose will be, accurate. But we can include, and we can incorporate that into the packet, is what I'm saying.
mhm.
So that we
Oh,
have a
absolutely.
consent form that we all are saying the same thing, so that there's not variation even amongst us when we're
But I make it very clear that like this is a serious problem that could lead to significant disability. We have this possible treatment. It has major side effects, and like these side effects are real. This is not like a 1 in a million side effect. Like at least 5% of people who get this drug will bleed into their brain, like, and that can be very dangerous. And, you know, so, but at the same time, I tell them, like, if it were me, I would definitely want the drug. Like, I don't want to have I don't want to be, like, permanently disabled, like a major stroke. Huh?
Get it tattooed on your chest.
Yeah, dude.
No TPA.
DNR, pro TPA.
Like a time limit.
Only within 6 hours.
TPA less than 150.
4.5.
Oh, only the 3 though, right? All right. So this is a really interesting study that was just published in 2018. This is expanding the IV TPA window using like MRI. This is the wake up study. They had a lot of wake up strokes in this study. This is an RCT of more than 500 patients who had stroke of unknown onset, and then they had a favorable MRI profile. I'm not really going to get too much into like what a favorable MRI profile is. But this is somebody who had an MRI that seems to indicate that their stroke probably happened within the last 4.5 to 5 hours. And they gave them TPA versus placebo. They excluded patients who went and got thrombectomy. And their primary outcome was an MRS of 0 to 1 at 90 days. And the primary outcome favored TPA. There was an 11% absolute risk reduction, which is an NNT of 9. Now, they did have a little bit of a trend, not statistically significant, but a trend towards increased mortality. And as expected, you know, using the more narrow definition, they had about a 1.5% increased risk of symptomatic intracranial hemorrhage. So this is like data to me that even in that wake-up stroke, like you're not off the hook. I mean, I wouldn't give IV TPA without a perfusion study at our hospital, but a wake-up stroke who has a demonstrable deficit, like a significant deficit, who might need something, I'm definitely transferring that patient. You know, pre-existing dementia and all that other stuff aside, I mean, like if you have a functional patient who wakes up with a bad stroke, like I don't think it's any longer that you can just whatever, put them in the corner and just admit them. Like they might be a candidate for further therapy down the road, even IV TPA.
What has been that was a question I was thinking of. What has been the, I guess, process before that? They wake up,
You don't get you
No onset.
you get admitted.
yeah, okay.
This I mean before intervention and before
Unless you'd only been sleeping for 2 hours.
right.
Because you were up and you were.
But basically, I mean, you got all the other stroke stuff and workup, but like you got admitted. I mean, that's basically what happened. Yeah.
And so you could send them to possibly get further workup.
Now, you don't know. They might not have a favorable profile. They might not have a large vessel occlusion. They might not be able to get anything done. But like, you can't just keep them here if it's a significant stroke. And I mean, there's tons of gray areas. You know, we see tons of patients who have these like weird, vague symptoms. And most of the time, in my experience, like vagary is not a stroke. What if you remember Jeremy Payne, the neurologist from Arizona? He gave us a grand rounds, and he ended it. He's like, just remember, just because it's vague doesn't mean it's neurology.
Yeah.
And he like dropped the mic and like walked off the stage. It was. So, anyways, let's talk a little bit about EVT. All right, big vessels. These patients need large vessel occlusions. The best data is for the ICA, the internal carotid artery, and the M1 branch of the MCA. Big vessels. There's less data, but still some data for ACA, PCA, and like the M2 and M3 branches. You know, the question I've always asked is like, what the hell is an LVO? What does it mean? And you know, the best data is the internal carotid artery and the M1 vessel or branch, of the MCA. And you know, this is how the MCA travels, right? The M1 is the horizontal segment of the MCA where you might see that hyperdense MCA sign. The M2 segment out near the Sylvian fissure, that's where you might see that Sylvian dot sign. So EVT is not a replacement for IV TPA. I mean, this can't be stressed enough. Like, you still need to consider the patient for IV TPA. Most patients in these studies are still getting IV TPA before they get their EVT. Patient selection is key. I mean, only a very small percentage of patients are going to be eligible for this therapy, but in that small subset of patients, it does seem to help. And you have to have an LVO, a large vessel occlusion. ICA in the M1 segment of the MCA is definitely the clearest indication. And the best evidence is for within 6 hours of onset. Now, there is data like 18, 24 hours, but the best data is M1 branch of the MCA, the ICA in 6 hours. Some studies use perfusion data to further stratify patients, and then there are studies that look at other vessels, and then up to 24 hours. It's estimated that only 10% of patients who present with a stroke are going to have a proximal LVO and present within 6 hours. So maybe 1 out of 10 people who come in with a stroke might be a candidate for this therapy.
And if they come to us at 4.5 hours.
Yeah, exactly. Oh, I know. And then they don't want to take a helicopter ride because it's too expensive. So these are very inclusive. These are very broad kind of inclusion criteria, but they might be a candidate for EVT if they've had a stroke within 24 hours. If they have a big deficit, they have to have limited early ischemic changes on their CT. They have to have a large vessel occlusion, and you got to be able to get to it within 24 hours, hopefully 6. All right, this is all the EVT trial summary right here. So since 2015, there have been now 7 big studies published, all with cool acronyms: Mr. Clean, Escape, Swift Prime, Dawn. I mean, I don't know where they come up with these. They're fantastic. So they're all, the timing is listed there. They all have various inclusion criteria. Like some of these more recent ones, like Dawn and Diffuse, have included patients up to 16, up to 24 hours. The patients who are being included later are usually getting a perfusion study to risk stratify them to see if they're a better candidate for that therapy. They've all showed a benefit, and some of these numbers are impressive. Like they have NNTs of 3, like a 30% absolute risk benefit in some of these studies. The data is pretty compelling. And I think this is set. There's 7 studies published in the last 5 years that have all shown a benefit, and there's hundreds and hundreds of patients involved, and I think this is pretty much good to go.
So the NNT for the TPA though is 8. Can they really report an NNT of 3 if half
Hold on a
of those
second here.
patients?
You got that's
yeah,
that
Mhm.
just before you even I don't mean to interrupt, but
No,
before you
you
even
know
finish the
what I'm
question,
trying to ask,
these patients, first of all,
Most of these
of
patients,
all the strokes, there's only going to be a couple percent. Well, I don't remember the number from the registry, but only some of them are going to qualify for TPA.
Right.
From that group that qualify for TPA, very few of them are going to therefore qualify for this. This is just LVOs, just cortical syndromes, just big vessels. So it's difficult to compare the efficacy or the number needed to treat from the
Right,
IPTPA.
it's not all
They're
TPA
totally
candidates,
different
it's
patients.
totally different candidates, got it,
And
okay.
not only that, it's that is the one thing that you really get from getting granular with these trials is that these are it's been estimated to represent 2% of strokes overall, at least in the literature. In the community, clearly we're going to be doing a lot more of these, but this is a very, very, very small subset of stroke patients.
And these NNTs are with respect to treating. Most of them, the control group was TPA.
okay, so
Except for one.
And then the intervention
So-
group was TPA plus intervention, right?
yes, in most of these studies, 75 to 80, even up to 90% of patients are getting TPA. So they're comparing it to standard medical therapy, which is mostly TPA,
Some of the
versus
patients arrive
TPA
after
plus
25.
an intervention. And their NNTs are to achieve a functional independence, a modified Rankin score of 0 to 2, versus 3 to 6. That's in the little footnotes down there, but
Are these all US studies?
yes. Well, actually, no, they're not. Some of them are European. If I'm not some of them are European for sure. If I'm not, gosh, I believe Revascat was European, but
So I
that-
don't know if it works.
these are all these are honestly I think out of all these, I think at least 5 of them were published in the New England Journal of Medicine, and the other ones were published in the
2 different
Lancet.
issues.
These are not the I don't want to bag at any countries, but like the Turkish Journal of Medicine or something like that. You know,
Borneo.
yeah, this is not
Journal of Investigative Neurology.
yeah, these are like big studies published in big, powerful, impactful journals. So, I mean, the guidelines basically just reflect what we talked about. Like, you know, patients eligible for IV alteplase should receive alteplase even if EVT is being considered. Again, it's not a replacement for IV TPA. And, you know, they should receive or at least be considered for mechanical thrombectomy if they meet the criteria that we talked about earlier. And, you know, in more advanced centers with like ready access to more advanced imaging, you know, they might be able to do this in certain patients with a favorable perfusion study out to like 24 hours. All right. So
Before you go, can you go back to the summary of the trial? I did want to say something about the NNTs here because again, this is sort of the EBM nerd thing, and I don't know how interesting this is to the general kind of like how you interpret the guidelines or like how we're reading this actually. But the NNTs here are very low, and it's kind of shocking. If you look at the Dawn trial, for example, I think that 49% of the intervention group had an MRS of less than 2. 50%, that's 1 in 2 large vessel occlusion cortical strokes walk out of the hospital and go home. Like, that is insane, right? So why is that happening? Probably that these NNTs are a little bit exaggerated because most of these trials were stopped early.
yes.
And when you stop trials early, it doesn't mean that the effect, when you stop trials early for benefit, that's an important differentiation. When you stop trials early for benefit, because all these trials were stopped early because Mr. Clean came out and showed a benefit, and so now it's unethical to not treat. So anyway, this is an interesting sort of sciencey thing of how ethics kind of interrupt, because all these trials were stopped early, they're going to overestimate their benefit. It doesn't mean it's not real. It just means that some of these NNTs you're seeing may not reflect like actual like real life.
Is
Yes.
there anything retrospective out there yet?
Yes, there's observational trials, and
Yeah.
they're coming out. And there's actually what's probably even a little bit, probably a good. But again, like if you do a meta-analysis of this data, your NNT is going to be very, very like wow, like right, because these are all gonna kind of falsely elevate the benefit a little bit. But I mean, that's just something to consider. It doesn't really change how you interpret the overall.
Yeah, I think like the first 3 trials were all published in the same issue of the New England Journal, and one of them showed a benefit, so the other 2 were stopped a bit early because, like, I mean, that Extend IA trial, I mean, there's only 70 patients
Exactly.
for a reason. You know, that being said, I mean, to me, this stands up. Like, it's consistent. Every trial shows a consistent benefit. You know, the NNTs are fairly similar. You don't have 3 negative studies and 3 positive studies.
It's not like IVTPA where it's totally inconsistent.
So, what does this really mean for us with this position? I mean, to me, it just makes it more difficult, to be honest. I mean, I think given the CVT data, as well as this Wake Up IV TPA trial, you know, that you might be able to guide IV TPA in patients who were previously outside of that window, I think it's reasonable to transfer any major stroke who has major deficits or non-minor deficits within 24 hours. You know, definitely within 6 hours, 100%, like you need to get that patient out of the door. In the later windows, that might be a decent time to consult over the phone with a neurologist at Renown if you think it's indicated. I mean, there's going to be a lot of borderline cases. Every case is unique. There's always going to be extenuating circumstances. You know, patient doesn't want to be transferred, doesn't want the therapy. You know, you're not really sure about the timing of onset. Like the symptoms are waxing and waning. Like I never said this is going to be easy, but these patients who have major strokes, I think it's pretty reasonable to transfer anybody who's at it like less than 24 hours. And, you know, 23 hours, they're probably not going to get there in time anyways, but, you know, I think we got to like expand that transfer window a little bit. And my understanding is that Renown, like they say they want these patients, like even when they were on divert and they wouldn't take anything, they were taking strokes and they were taking trauma. So like they're going to take these acute strokes.
Do you have an idea of how many years of harm for EVT? Like just a ballpark?
None of these actually showed like any major harm beyond just IV TPA.
Versus a TPA.
Yeah. None of them showed any like significant harm beyond IV TPA alone.
So these were not placebo trials. That's important. Except for
Yeah.
except for Extend IA, I think that
Alright, so they're no worse than TBA.
yes, in terms of ICH and
And are
direct
they
harm.
going in and like grabbing clot? Are
It
they
depends on the study. That's actually
dissolving the clot? Like,
They're using a, well, I mean, I don't know the details, but there were some studies before this that were negative, and some of the editorials I read, purported that it was like the better devices.
Well, if you
How
remember the
universal are
interventionalist who came and talked
Yeah,
to
Dr.
us,
Rangaswamy,
he really talked about that
Raj,
once they
he's
changed their tool,
right. Hmm.
that I think that was when they started.
that's when the benefit is.
Yeah.
That's my that's
Yes.
he kind of showed us the 2
Hmm.
techniques, and then
They use a clot retriever.
Mercy, I think.
Yeah.
Yeah.
Clot retriever. I think that's
Yeah.
like thrombectomy, like scooping out the clot.
some of the first trials actually were
Kind of like they like kind of suck into a little basket. I mean,
The,
yeah.
prevents like a downstream shower.
But they don't do like IA TPA necessarily.
No,
They might do a little bit of it, but they like to suck the clot out with this little basket thing.
which is a bummer. They did that in the first trial.
Total bummer, man.
They were negative, and they did one trial was like, well, squirt a little IV catheter direct TPA in there, and if there's no recannulation, then thrombectomy per physician's discretion. Now that's kind of a weird trial design, but that's what they were doing, and those were negative. And then they started doing these mechanical thrombectomy devices, and they've all been positive since. So there must be something about the device. And kudos to the researchers, right? Because you get 3 larger RCTs that are published, and I mean, it kind of puts the kibosh on interventional therapy for stroke unless you're very diligent. Somebody out there that was doing these knew they were working.
Somebody out there who had
Yeah.
awesome outcomes.
Yeah, they're like,
compared to
we
everybody
have
else.
to,
What are
yeah,
you talking about? Mine
like
are
we
awesome.
have to push this, and they did, and this is what they found. Such a great story, of how science.
Can't wait for the movie.
It's gonna be great. It's gonna be Peter Jackson. It's gonna be like The
Are you
Hobbit.
watching that movie or?
All right. So again, major strokes. So stroke scale 4 or more, or any potentially disabling deficit within 24 hours. I think it's reasonable to transfer that patient. Now, do you do a CTA prior to transfer? We talked about this, but I would personally say no in patients you're transferring regardless. Like the person who presents within a couple of hours or 30 minutes, like that patient is getting transferred 100% no matter what. You have to assess them for the IV TPA eligibility, but the CTA is not going to change my decision making whatsoever. I do think it's very useful in intermediate patients or like the weird ones where you're not really sure what to do. And I had a case recently of this guy who had Parkinson's, and he had some speech difficulty at baseline, and he came in with like aphasia, and of course his family wasn't there when he first came in, and I'm just like, oh my God, what am I gonna do? Is this guy having a stroke, or is he just, is he septic, and that's why he like can't talk as much as he normally does? And finally, his wife came, and she's like, oh yeah, he has problems with speech, but never this bad. And so I CTA him, and he gets back from CT. Unfortunately, 30 minutes later, he's like way better. And the CTA is negative, and I admitted him here for TIA, So in that instance, it was helpful to me. But these patients who are, like, you're not uncertain about the diagnosis. Like, you walk in the door, and you're like, wow, this person's having a huge stroke. That person, who cares about the CTA? Just do a non-contrast head CT, assess them for IV TPA, and get them transferred.
Can we have some of your packets upstairs?
So I
When you
made
make
packets
them?
at CVs and C, but I'm gonna make news policies and packets, and yes.
Because in the past, like, we've had 1 or 2, and like,
Yes.
I kind of come running downstairs and kind of, where's your stroke folder?
Mhm.
Can I please see it? Because
We
I
don't
don't
have one at
ever
Barton
give TPA, and I don't really know what to do. Kind of out your
Yeah.
folder. You think you're burning.
Yeah, that's a good idea. All right, so we're going to get a non-contrast head CT. It's still our first choice of imaging. Minor early ischemic changes are not a contraindication to TPA. Large areas of hypoattenuation probably are. There's really no great evidence for blood pressure goals outside of TPA candidates. This short-term dual antiplatelet therapy is indicated for minor strokes and high-risk TIAs. I think IV TPA is well supported in the 0 to 3 hour window. Less convincing in the 3 to 4.5 hour window, but it's still recommended. You got to carefully assess these exclusion criteria for TPA, use a checklist. EVT definitely works for the right patients. It's a minority of patients, but it definitely seems to work. And there is some data now showing this extended window for EVT and IVTPA up to 24 hours, so it might expand our transfer window. And that's it. Thanks so much. Sorry that went on very much.